Welcome to your annual mandatory training session. Once you have watched this video, you will be required to complete a short questionnaire before attending a face-to-face session. At the half-an-hour face-to-face session, you will be required to demonstrate that you have the competence to perform effective CPR on a mannequin. Please note you are not required to undertake this session if you have a valid ILS certificate within the last 12 months. The chain of survival is the Resuscitation Council's logo, and we use this as the objectives for this session. All links in the chain of survival should be considered as important in order to achieve a positive outcome for the patient. A chain is only as strong as its weakest link. Arguably, the first link in the chain, which is prevention of cardiac arrest, is the most important, and we will spend some time in this session talking through the deteriorating patient. The second link is early CPR once a cardiac arrest is confirmed, and CPR is essential to keep blood supply going to the vital organs, namely the brain and heart. This video will demonstrate effective CPR. The third link in the chain of survival is early defibrillation. Research suggests that early defibrillation is key in reversing shock or cardiac arrests, with survival dropping by 10% for every minute defibrillation is delayed. The gold standard aim is to deliver the first shock if needed within 3 minutes of arrest. Within our organisation, you are able to use the defibrillator if you have either an ILS or ALS qualification. We will discuss this further later on. The final link in the chain of survival is post-resuscitation care. Generally speaking, this needs to happen in a high care area, such as critical care or coronary care. And this is because patients can be very unstable in the period immediately after return of spontaneous circulation and need close or intensive monitoring with ongoing management of the cause of arrest. This also highlights that should a patient have a treatment escalation plan stating they would not be for critical care, there should be serious consideration as to whether they should also have a DNA CPR, allow a natural death order in place, as we know long-term outcomes are worse for patients that are not given the appropriate level of care in the fourth link of the chain. We will also discuss DNA CPR, allow a natural death orders later in this presentation. It is important that you know how to call for help wherever you work within our organisation. On the pool site, the call is for a medical emergency team for any emergency situation, including cardiac arrests. The call is made on 2222, and the caller must state which team they want, because we have several medical emergency teams, and as precise a location as possible. The adult medical emergency team comprises of a medical registrar with junior medical doctors, anaesthetics, outreach and a porter, plus resuscitation team during daytime hours. The response time for the medical emergency team is 2 minutes. The news team is activated for any patient scoring 7 or more on their news score, or causing concern in the ward environment, but do not require the level of a medical emergency call, or they don't have a treatment escalation plan stating that they are not for news. The news team is smaller, consisting of the medical registrar, junior medical doctors and outreach clinical practitioners, and the response time for the news team is 5 minutes.
On the Bournemouth site, dialing 2222, you can request 3 different emergency teams. We have a cardiac arrest team, a peri-arrest team and a medical assistance team. The cardiac arrest team should be with you within 3 minutes, and it will include the medical registrar, junior doctors on take, anaesthetic registrar, clinical site nurse and outreach nurse. Activating the peri-arrest team will summon the medical registrar, junior doctors, clinical site team and outreach nurse, and they should be expected to be with you within 5 minutes. If you ask for a medical assistance team, you will get the junior doctors, the clinical site nurse and the outreach nurse, again within 5 minutes. At Christchurch Hospital, we only have the cardiac arrest team, who again should be with you within 3 minutes.
This slide is just to give an idea of the workload of the emergency teams, and we have the figures for pool for the last 3 years for comparison. Noticeably, the number of calls has been going up as a trend, but this could be due to our excellent early recognition work, but also some is attributable to the change in the trigger for new schools from 9 down to 7. Most pleasingly, however, is that we are concurrently seeing a drop in the number of cardiac arrests on an annual basis, with a very low number there for 2020. In terms of outcome survival figures, this relates purely to the in-hospital cardiac arrests on pool site. We have seen the best figures we have had in the last year, and this is partly due to the early deterioration recognition work, plus an improved uptake in the use of treatment escalation plans during the pandemic. So overall, we've had a reduction in the number of cardiac arrests and an improved survival to discharge from hospital. These can only be positive findings in what has been a difficult time.
Our emergency teams at the Royal Bournemouth Hospital are similarly busy, responding to between 600 and 1,000 calls per year with a mixture of acuity. It is important to note that the red columns and the figures represented there are cardiac arrest calls and not actual cardiac arrests. At the Royal Bournemouth Hospital, we have on average 100 in-hospital cardiac arrests per year. This slide represents outcomes from those 100 cardiac arrests per year. We've remained relatively stable, seeing between 35 and 38% of our in-hospital cardiac arrests survive to discharge.
Eorbs is now used around the organisation as a way of entering and calculating the adult patient's News 2 score. In order to get that score, data must be entered into each parameter on the iPad. There are some variants, and we can use Scale 2 for oxygen saturations. This is currently only available on the pool site, but should only be selected on those patients that are known to have chronic hypercapnia, which is that they retain carbon dioxide. This should be documented in the patient's notes by someone of an appropriate level, i.e. registrar, and it's hoped that this will be adopted on the Bournemouth site in the near future. News 2 is a nationally mandated system, and all NHS organisations must use this to track a patient's physiological changes and trigger a response. Evidence shows that the higher the News score, the higher the mortality. Therefore, action must be taken in accordance with the graded response strategies presented on the next slides. Failure to escalate appropriately can lead to a delay in recognition, an increased risk critical care admission, and an increased risk of cardiac arrest. If the decision at ward level is to not escalate at that time, there must be either documented evidence that the patient is not for escalation or clearly documented reasons why it has been decided not to escalate on that occasion. It is also worth noting that the News scoring system is an adjunct to your assessment of the patient and should not prevent escalation where there is concern. Equally, if a relative or carer is expressing concern that the patient is not their usual self, these concerns should be taken seriously and acted upon, even if the News score does not indicate this. This slide is the Escalation Protocol for Poole Hospital. For patients, we classify them as low, medium, high or critical risk, depending on their News 2 score. The main points to take from this slide is that a News of 5 or more, the mantra is to think sepsis and complete the sepsis screening tool. High-risk patients, those with a score of 5 or 6, should get a medical or outreach review within 30 minutes of that score, and patients with a News of 7 or more indicate the need for a News call to be placed on 2222, and the patient will be assessed and reviewed by the News team within 5 minutes. The frequency of observations is calculated based on that News score, but please ensure that this frequency is appropriate for the level of observation that the patient requires. For example, a News score of 0 places the patient onto 12-hourly observations, and this may not be adequate and can be overridden.
At the Bournemouth site, the News escalation process is again similarly split into different categories. A News score of 5 or 6 is deemed high risk. The patient needs a medical review within 60 minutes. You may also contact the critical care outreach team and consider putting out a medical assistance call if required. A News of 7 or 8 is deemed a high risk patient. Again, the patient needs a medical review at registrar level within 30 minutes, similarly considering a peri-arrest call and contacting the critical care outreach team. A News of 9 and above is a critically unwell patient and needs an urgent clinical review. We would recommend a peri-arrest call, but again, the patient needs to be seen by a clinician within 30 minutes.
In the context of deterioration, when a patient becomes acutely unwell, it is vital that all potential causes for deterioration are explored. The protocol on this slide has been developed by the Wessex Deteriorating Patient Network and prompts the user to consider all causes, including sepsis. If sepsis is considered to be the cause, the sepsis screening tool should be used and the sepsis 6 treatment plan initiated where appropriate. Regardless of the cause of deterioration, when we first come and see our patient and find they are unwell, the approach that we use to assess them is the ABCDE approach, or A to E approach. By using this structure, we can recognise and treat the most life-threatening problems first, thus preventing further deterioration and/or cardiac arrest. The process should be to assess, treat if you can, but if you can't, then that is a very good time to call for help. If you do give any treatment, then it's important to reassess the effectiveness of that treatment. We start with airway first, as a compromised airway is the most life-threatening problem, and we only move on to breathing once we are happy with airway. Airway is most commonly affected by a reduction in conscious level. Airway should be assessed using look, listen and feel, and any concerns will generally require urgent assistance. If the airway is obstructed, basic manoeuvres such as suction, head tilt chin lift or the lateral position will generally buy time until help arrives. If the airway is patent and the patient can talk to you easily, then it is okay to move on to assess breathing. The effectiveness of breathing is again assessed using look, listen and feel. counting the respiratory rate over a full minute whilst also looking at the depth, symmetry and pattern of breathing. Is the patient working hard to breathe or not able to complete full sentences? Is there any evidence of central cyanosis, which is blueness around the lips or tongue? What are the patient's oxygen saturations? Are they within the target range for that patient? And importantly, we need to know what oxygen, if any, they require to maintain those saturations. Basic interventions such as nebulizers, sitting the patient up, encouraging coughing may help. But if there is concern and the patient is unwell, high flow oxygen at 15 litres via a non-rebreathe mask should be applied and help sort. If we're happy with breathing and there isn't a problem with oxygenation, we can move on to assess circulation. And what we want to know is the circulation adequate enough to deliver oxygen to the tissues? And in order to assess the effectiveness of circulation, there is a simple approach we advocate called the circle of circulation. Starting with the patient's hands, do they feel cold, hot, clammy or dry? Moving up, is there a radial pulse? Is it easily palpable? Is it regular or irregular? And what is the rate? Moving up to check their blood pressure. Ideally, this should be manually in the unwell patient, but have we got a blood pressure that we're happy with? Moving up to check the temperature. Is it high or low? Either of those may indicate a septic cause. Moving on to check the capillary refill time. Central capillary refill time is preferred, where we press for 5 seconds on the chest wall. The skin should return to normal colour in around 2 seconds. In younger patients, this can also be performed on a finger, but the hand must be at the heart level and the patient in a warm environment for this to be accurate. Is ECG monitoring required or a 12 lead, particularly if there's any irregular rhythm or their patient is complaining of chest pain? And we would also like to know that there is end organ perfusion. Are the kidneys working properly and receiving adequate blood supply? So we can find this out by checking the urine output. Is it adequate for the patient's weight? For example, over 0.5 ml per kilo per hour. Also in circulation, does the patient have a cannula and IV access? And if so, is any blood testing required that might help us with our diagnosis? The management of the majority of acute circulation issues is to deliver fluid resuscitation until circulation normalises, and this is usually in 500 ml boluses. If we're happy with circulation, we can move on to assess disability, or D is de brain, which is where we are looking at the neurological state of the patient. We start with our ACVA-POO assessment. Is the patient alert? Are they newly confused? Do they only respond to voice? Or do they only respond to pain by way of a trapezius squeeze? If they don't respond to pain, they are unresponsive. Any patient in the P or U, the POO of AVPOO, is at risk of airway compromise and should have an emergency call put out for anaesthetic support if there is any concern. As part of the disability assessment, blood sugar needs to be checked and treated if it is less than 4 millimoles per litre. Pupillary response should also be assessed for size and reactivity to light. This is also a good time to assess the patient's level of pain if they have any. The final step of the A2E assessment is exposure. This is examining the patient from head to toe, front and back for anything that shouldn't be there, such as rashes, bleeding, swelling, sites of infection, etc. If at any point through the A to E assessment the condition of the patient changes, then go back to A. Equally, there should be a reassessment to make sure that any interventions that have been performed have had the desired effect. We will now show a demonstration of an A2E assessment. Phil is going to assess Laura, a patient who has been admitted with acute asthma.
Morning, Laura. My name's Phil. I'm one of the AMU nurses. One of the HCAs has asked me to come and have a quick look at you. I noticed you're a little bit short of breath there. How are you feeling?
Oh, I've had 3 of these, and I'm still wheezy.
Okay, fine. We'll give you a little assessment. I'm going to sit you up a little bit further and pop the top of this trolley up. Is that all right?
Yeah.
Does that make you a little bit more comfortable? Does that look better? I noticed that nebulizer's empty. Should we just pop that off? Is that okay? And I'll grab you some oxygen, I think. And we'll get you another nebulizer shortly. I notice you can't really talk to me fully.
No.
No? Has that been going on for a little while?
Yeah.
Yep. Okay, we'll get some help shortly. You happy with this mask on?
Yeah.
Yeah. Is that a bit easier sitting upright?
Yeah. Yes.
So let me just fill this bag up. Okay, just get a tight fit on that. Is that going to be okay on there? Happy with that? So I'm just going to give you a quick once over. I'm just going to check your breathing. Is that okay? I'm going to put a little peg on your finger. You've had these before.
Yeah.
Just going to have a look at your respiratory rate. Okay, I can see you're working quite hard to breathe there, and your oxygen levels are a little bit low. So we'll keep you on that oxygen for now, and then we'll get you some more nebulizers once we get some more help. So your respiratory rate's up a little bit, your saturation's a little bit low, we've got you some oxygen. I can hear you a little bit wheezy, and you can't really talk to me fully. Okay, I'm going to have a quick look at your circulation, is that alright? I notice you're on a heart monitor already, but let me just double check. Okay, so your heart's a little bit fast, but it's nice and regular and nice and strong. I'm going to check your blood pressure as well, if I may. Can you just pop this on this side, is that alright? You've not got any needles in your arm at the moment? No. Okay, just relax that one down there. It's just going to go nice and tight on your arm. Okay, can I just borrow a finger again and give it a little squeeze? Is that all right? Just borrow this one. Okay, so your cap refill time's a little bit slow. That's 3 seconds as well. You've not had any problems with your waterworks at all at the moment? No? Okay, that's absolutely fine. And we'll check your temperature. Okay, just nice and still. Well done. Okay, and your temperature's normal. So you're nice and alert and awake and you know where you are while you're in hospital? Yeah. Okay, excellent stuff. And we'll check your blood sugar. I'll get one of my colleagues to come and check your blood sugar. May I have a quick look in your eyes? Is that going to be okay? So just fix a point across the room there for me. Just going to have a quick look in your eyes. Yeah, that's great. Okay, your pupils are equally reactive to light, that's normal. What I also need to do is have a quick exposure to see if there's anything else that we're not picking up. Is that okay? Do you mind if I have a quick look down? Nothing else going on in terms of your chest? No. You're just working quite hard to breathe? Yeah. Not got any abdominal pain, anything along those lines? May I just expose your legs and have a quick look up and down there? And you've passed urine all right today as normal? Yeah. Okay, fine. Excuse me a second. Yeah. Okay, can I just lean you forward a second? I'll get somebody to come and have a listen to your chest shortly as well. Nothing else untoward there. Okay, so you're obviously quite unwell and you're struggling to breathe, so I'm going to get one of my colleagues from the outreach team to come and give you a quick assessment, and then we'll get you in up for some more nebulizers and some further treatment. Does that sound okay? Yeah. Okay, lovely. I'll be back in a second.
So Phil has assessed Laura and he's concerned. Her new score has gone up and he's asked for help. When handing over the care of patient to another team for further input, either face-to-face or by telephone, the S-bar communication tool should be used. First introduce yourself, then describe the situation. What prompted you to put out the call for help? Give a brief background history to the patient, including any relevant past medical history. Hand over your assessment of the patient using the A to E approach. And finally, give your recommendation or ask for a response. Here is Phil handing over to the outreach team.
Hi Pat, thanks for coming to give you some help. We've got Laura here, who's a 48-year-old female with a history of asthma. Situation is she's got a highly warning score of 6 and I'm worried about her. So I've asked you to come and give her a clinical assessment. She's had 3 back-to-back salbutamol nebulizers, which seem to be having little impact at the moment. On my assessment, her air is nice and patent. She's using a few accessory muscles to breathe. On my arrival on nebulizers, her oxygen stats were 90. We've switched that to non-rebreathe oxygen and they've increased up to 95%. So she's 95% at the moment. She's got an audible wheeze. I haven't auscultated her chest yet. Circulation-wise, she's got a blood pressure of 128/80. She's got a heart rate of 106. It feels regular and strong radially. At the moment, she's got no IV access. She's passing urine normally. She's got a temperature of 36.9. Disability-wise, she's awake and orientated, so I think she's A on the AVPU score. We haven't checked her blood sugar yet. I've checked her pupils and they're equal and reactive to light. And then on exposure, actually, there's nil of note. Recommendation is we need to increase her treatment for severe acute asthma, if you're happy to help me out with that.
Yeah, I think we do. Has she had bloods done today?
She had no bloods, I don't think, today.
And when did she come into hospital?
She came in yesterday.
Yesterday, so you've been overnight. So she's had 3 nebs back to back, so something's changed this morning, hasn't it? She's got worse.
She's got worse this morning, yeah.
Okay, right, we'll do an assessment and we'll start some other treatments. If you wouldn't mind staying to give me a hand, that would be great.
No problem at all.
Okay, thank you. Anaphylaxis is an acute life-threatening event as a result of a severe reaction to an allergen. This could be medications, food, or insect stings, for example. If during the course of your A2E assessment the patient shows any signs of anaphylaxis, such as facial swelling, wheeze, a high heart rate, low blood pressure, reduced level of consciousness, and/or a rash, put out an emergency call and administer 0.5 milligram of intramuscular dose adrenaline 1 in 1,000 solution. This dose can be repeated after 5 minutes if required. Intramuscular adrenaline is stored in the emergency drugs box or the drugs roll in the emergency trolley. When you open the box or the roll, you may find a pre-filled syringe or an ampule and needle. If it were an ampule, you would need to draw up 0.5 ml from an ampule of 1 in 1,000, or if it were a pre-filled syringe, you would need to expel 0.5 ml of 1 in 1,000. Intramuscular adrenaline does not require a prescription prior to administration in life-threatening anaphylaxis. So we've discussed the first link in the chain of survival, which is the deteriorating patient. We are now going to move on to the second link in the chain of survival, which is early CPR to buy time. This will be a real-time demonstration run-through, followed by some dialogue as to what we've done and why. Stage 3 and 4, which is the practical bit for you guys, will be covered on the session when you come to see us face-to-face. Morning, Fred. How are you doing today? Fred? Fred? Can I have some help, please?
Pat, can I help you?
Yeah, Fred's in cardiac arrest. Can you put out a 2222 call, come back with the trolley and get yourself into level 3 PPE? I'm going to start chest compressions.
Okay. Okay, Pat, the girls are getting the trolley. They're going to put that outside. I've come to take over from you.
Fantastic. I'll count you in.
Yep.
5, 4, 3, 2, 1. I'm going to go and get into level 3 PPE. Okay, so you've just seen the demonstration of basic life support in a negative COVID patient. In that situation, I was wearing level 2 PPE, which would be the basic requirement for patient care at the moment. And if anything other than compressions is being performed, the requirement is to go into level 3 PPE, as Laura demonstrated. Now, these guidelines are subject to change, and we need to regularly keep updated with the infection control pages to know what our level of PPE is required in clinical practice. But in our current state, this is what our recommendation is. So going back to our patient here, Fred, I've come in to see Fred, and as I approach, he doesn't look very well in the bed. So I've got an immediate cause for concern. So I want to quickly establish whether Fred is aware that I'm here. So we use what's called the SSS approach in resuscitation. So the first consideration is always the safety of yourself. So I was in my level 2 PPE. I made sure there was nothing here that's going to cause me any harm, and it is safe for me to approach in this environment. The next S is to stimulate the patient. So we just want to see whether Fred's having a nice deep sleep or whether actually there is a cause for concern. So we're going to do that with a shake and shout. So we're going to say, Fred, can you hear me? Open your eyes. And you need to give some reasonable stimulation to get a response from Fred. If I get nothing at this point, at best Fred is unconscious. At worst, this could be a cardiac arrest. So at this point, I don't want to be on my own. I'm going to make my third S, which is a shout out for help. So I'm going to shout for a colleague. Laura, can you come and give me a hand, please? And if I've got an emergency bell, I'm going to press that to attract attention to where I am. So I'm probably going to put Fred in a better position. I'm going to put the head of the bed down. So we need to confirm whether Fred's in cardiac arrest or he's just unconscious. And the way that we do that is by exposing the chest so that we can see whether Fred is breathing normally. And that's a really important statement. And we're also going to find the carotid pulse and decide whether we can feel carotid pulse, and we have up to 10 seconds to make that decision. If Fred has no pulse, not breathing normally, there's no other signs of life, then this is a cardiac arrest. So at this point, we need to make sure help is coming. So Laura kindly responded to my shout for help, so I'm going to direct her to put out a medical emergency call at Poole Hospital or a cardiac arrest call if I'm at Bournemouth Hospital. It's the adult medical emergency team that we would like at Poole, and the number to activate is them on 2222, and the same for Bournemouth, 2222, but stating that you would like the cardiac arrest team. They need to know the location of your event, so if you can be precise on that, so a ward or department, and also a bed number or bay number is really helpful when the team are coming running to your aid. In the meantime, I'm in my level 2 PPE. It's safe for me to start chest compressions, but nothing to do with ventilation at this stage of basic life support. If Fred had an oxygen mask on at this point, I would leave it in place because it provides a barrier to anything that may well come out as I'm doing chest compressions, but I'm not going to apply an oxygen mask at this point. So in order to do effective chest compressions, we need to get our hand placement right. So ideally, the patient should be at our mid-thigh level. So you might need to get a stool, you might need to drop the bed height down, or you might even need to kneel on the bed with the patient. You're aiming to depress the sternum 5 to 6 centimetres, so you need reasonable force to do that. So to do that effectively, you need to be over the top of the patient's chest. So your shoulder should be in line with the heel of your hand on the sternum. Your hand position should be roughly mid-nipple line, heel of your hand on the breastbone, the sternum, and the other hand, fingers interlocked, or you can support the wrist, whatever feels comfortable for you. In order to achieve 5 to 6 centimetres compression depth, as we said, it's quite firm pressure that needs to be applied. And if I press down by 5 to 6 centimetres, I need to also allow the chest to recoil back to its natural height. The speed of compressions we're aiming for is 100 to 120 compressions a minute. And generally speaking, 1 and 2 and 3 and 4 is about the right tempo. Once I've started chest compressions, I'm not going to stop until my help comes back in her level 3 PPE. If I was completely alone out of hospital, I may find I can only continue for as long as I can physically, in which case I might have to stop. In hospital, we know that the response times for our emergency teams is rapid. There's additional help around so that we're able to hand those chest compressions over fairly quickly. So I'm going to continue with chest compressions like that. My only reason for stopping at this point might be if the patient shows signs of life. So if they start to object to what I'm doing, then clearly compressions are not required. I would stop and reassess the need for that. The only other reason for stopping, perhaps in hospital, if somebody presents you with a valid DNA CPR, allow a natural death form for that patient. So if we weren't aware of their resuscitation status when we found them collapsed, we would start CPR. If that form comes to light, then we can stop CPR at that point. Carrying on chest compressions until help arrives, really we want to minimise interruptions in compressions where possible. We know that we are the patient's beating heart at this point, and we want to keep blood going to the brain, and that's the purpose of our chest compressions, to keep the brain and the heart perfused. So when your help does arrive, in order to minimise interruption in chest compressions, we don't just stop and then get them to take over. We need a structured handover as we demonstrated previously. So I just like to count down from 5, 4, 3, 2, 1, and know the person next to me is able to then take over CPR with a minimal pause. Target is less than 5 seconds off the chest, whether we're going to deliver breaths, whether we're going to swap compressions or do anything with the defibrillator. Once you've handed over compressions to the person in level 3 PPE, then you need to leave the situation. The rest of the team will hopefully now be here and getting donned in their PPE, and unless you are required to come back into the room, you should do that in level 3 PPE. Otherwise, hand over to the team outside what you know about the patient, what you found and what you've done so far. You've just watched the demonstration of initial resuscitation of a green pathway patient. Key points are to limit the exposure to other members of the team, so as soon as the first person in level 3 PPE arrives, they should relieve the first responder at the earliest opportunity. Anyone else participating in the resuscitation from that point onwards should also be in level 3 PPE. If a cardiac arrest happens in a confirmed or suspected COVID patient, no compression should be commenced unless fully donned in level 3 PPE. If you are an ILS or ALS provider and trained in defibrillation, a shock may be delivered whilst in level 2 PPE, but no compressions started after that shock's delivered. These guidelines are available on the Trust intranet and will be subject to change as and when infection control measures change. Choking is a medical emergency. It is first necessary to determine how severe the choking is. Can they talk? Can they cough? If the answer is no and they are still conscious, there are manoeuvres we can do to help. Regardless of age, the first treatment is to attempt up to 5 back blows. If those fail to dislodge the foreign body, then in adults and children above 1 year old, up to 5 abdominal thrusts can be attempted. If the child is under 1 year old, abdominal thrusts should not be performed, but instead perform chest thrusts. Pregnant women should also not have abdominal thrusts performed and only back blows. If there is no improvement after the first round of manoeuvres, call for help, but repeat manoeuvres until the object is dislodged. If the patient loses consciousness at any time, then commence CPR. At this point, the purpose of the compressions is to push out the foreign body. We will now demonstrate the choking manoeuvres on a mannequin.
Now we're going to move on to look at the adult and paediatric choking guidelines. Initially, you need to assess the severity of choking to decide if this is a mild obstruction or a severe obstruction. If it's a severe obstruction, you need to inform the patient of what you're about to do, and you're going to attempt to lean them forwards and offer them some support. You then got up to 5 attempts at back blows, striking firmly between the shoulder blades, reassessing in between to see if the obstruction's been removed. If that's been ineffective, you're then going to inform the patient that you're going to move on to abdominal thrusts, and you're going to landmark finding an umbilicus or belly button or xiphisternum and joining the rib cage. And your fist then gets placed in between those two landmarks. Lean the patient forward if you're able to, and then you've got 5 attempts at good firm pulls diagonally upwards and inwards, aiming for a diaphragm. If that proves ineffective, then you're going to call for further help via 999 or 2222. If the patient is still conscious, then you're going to repeat the process back to 5 more back blows and 5 more abdominal thrusts if required. If the patient loses consciousness, you're going to start basic life support.
So following on from what Phil has just demonstrated, we're going to talk about choking in children now. And for the purposes of paediatric resuscitation, a child, as the mannequin here, is from 1 year to puberty. An infant is less than 1 year old. And what we do in choking in either of those age groups does vary slightly. So we'll just demonstrate both of those things. So if we have a child here who's choking, the first thing again we would like to know is whether he can cough effectively. If he can cough and clear it, we'll let him do that. If he looks like he's struggling and has an ineffective cough, then we need to step in and help. The first treatment again is going to be a back blow, and we're going to hit him sharply between the shoulder blades. This child is clearly going to be shorter than me, so I might need to kneel on the floor to support him over my hand. Or if it's a young child, I may well pop him over my lap in the head down position, because gravity always helps. Once you've got them into a position you're happy with, heel of your hand between the shoulder blades, you deliver a back blow and see if it works. You can repeat this up to 5 times. And if after the 5th attempt there's been no clearance of the obstruction, we move to the next manoeuvre, which is the abdominal thrust. Again, we might need to get lower down to be in height with the child, and those landmarks are the same, the belly button and the xiphisternum, and we pop a fist into that soft upper abdomen. Lean forward slightly again because gravity helps, inwards and upwards. We're going to try and clear that foreign body. We have up to 5 attempts. Obviously, if it comes out on the 3rd one, we don't carry on. If there's still no change, we give our 5 abdominal thrusts. If there's no improvement, at this point I need some assistance. I'm going to call my 2222. We need a paediatric emergency team. We're going to carry on whilst he's conscious with further back blows and further abdominal thrusts. The point at which the child loses consciousness, we lay them on the flat surface and we would start our CPR. Okay, so we'll now demonstrate how to manage a choking infant. So this is our under 1 year old. If the baby is choking, they're unlikely to be able to have a strong effective cough, and they certainly won't cough to command. So if there's anything obvious in the mouth that you think you can remove, be very careful about that, but sweep obvious foreign bodies or anything out of the mouth if you can. If the baby looks like they're struggling, then again we start with back blows. This time though, we're going to need to support the baby's jaw because they haven't got the strength to hold their head, and you're going to get them in a head down position over your lap or over your arm, heel of your hand between the shoulder blades, and again you're going to try up to 5. Check to see whether it's worked. If nothing's coming out, we keep going and we deliver all 5. If there's no change there, the second manoeuvre is different. We don't want to do anything across the abdomen in a baby, so we're going to do a chest thrust. So again, gravity helps. Get the baby head down over your lap or on your arm, and you need to now find a landmark on the chest. So roughly between mid-nipple line, 2 fingers on the chest, and these are sharp downward thrusts, and we're going to try up to 5. 1, 2, 3, 4, 5. And if there's no response to that and the baby's still conscious, we're going to turn the baby back over and we're going to try another 5 back blows. And we keep repeating those manoeuvres whilst they're conscious. I'm certainly going to need some additional help, so I'm going to put out my 2222 and an emergency call. And then if the baby loses consciousness, becomes floppy, again pop them onto a flat surface and we start CPR. We're just going to discuss here some modifications for paediatric resuscitation. Should you work regularly with children, you will need to undertake either paediatric basic life support or a PILS course, which is paediatric immediate life support. This section is designed to give a very brief overview of what may be required in the event of finding a child or infant in cardiac arrest. For the purposes of resuscitation, infants are 0 to 1 years old and children are 1 year to puberty. The most common reason for a child having a cardiac arrest is hypoxia, which is low levels of oxygen, secondary to either an airway or breathing problem. The same rules to approaching a child in cardiac arrest are that of an adult, starting with safety first, stimulating the child or infant and shouting for help if there's no response. If after a 10-second assessment there is no signs of normal breathing, then ideally we would start with 5 rescue breaths first. In COVID-19, this should not be attempted unless in level 3 PPE. If the 5 breaths fail to have any effect on the child, then the next stage is to move on to chest compressions. In infants, chest compressions are performed by putting 2 fingers onto the sternum, 1 finger up from the xiphisternum and depressing the chest 3 to 4 centimetres at a rate of 100 to 120 for 30 compressions. The other option for chest compressions in infants is to use the encircling technique, and this is if there is more than 1 rescuer. So hands are placed around the infant's chest and the thumbs on the sternum, roughly 1 finger below nipple line, and again depress 3 to 4 centimetres, allowing for full recoil of the chest. In children, chest compressions are performed using 1 or 2 hands on the sternum, 1 finger up from the xiphisternum, and depressing the chest 4 to 5 centimetres at a rate of 100 to 120 per minute for 30 compressions. The ratio is then 30 compressions to 2 breaths until handed over to the emergency team. Compression-only CPR can be carried out in the first instance if there is a risk attached to performing ventilations. So now we have resuscitation CPR established, we can move on to the third link in the chain of survival, which is early defibrillation. Early defibrillation is key to a successful outcome in shockable cardiac arrests. Any delay to defibrillation is likely to have an impact on that survival. Specific training is required to use the defibrillators in hospital, such as an ILS or ALS course. However, in the community there is a public access defibrillator programme, and any of you should be able to use an automated device in the face of an out-of-hospital cardiac arrest. These devices are usually kept in locked cabinets or in places like shops or travel hubs. The code to get to these defibrillators are usually provided by the ambulance service when making the 999 call. Someone should be collecting the nearest defibrillator whilst you or someone else start the chest compressions. The main points for safe defibrillation are firstly to prepare the chest before applying the pads. It may need to be shaved or dried. Apply the pads in the correct position, it's usually illustrated on the pads, and follow the verbal instructions from the device once you have switched it on. If a shock is required, please press the red shock button once you have made sure no one, including yourself, is touching the patient and oxygen has been removed. Once the shock has been delivered, chest compressions can be resumed straight away. It is quite safe to do so. The in-hospital devices, as illustrated on this slide, have additional functions for temporary pacing and cardioversion. If further advice or education is needed regarding defibrillation, please do get in touch with us. The following video will show the use of an automated external defibrillator as would be found in the community.
Hello, hello, can you hear me? Can you hear me? Can I have some help in here, please? 4, 5, 6.
Hi Laura, do you need a hand?
8, 9, 10. Yes, this patient's in cardiac arrest, Phil. Could you please go and put out an emergency call? Bring back the emergency trolley, please, and get into your level 3 PPE. If you can you bring a defib in?
Okay, I'll go and give you that for you now.
Thank you.
Hi Laura, back.
Hi. Oh, lovely. You've got the bag mask. You do 2 breaths, I can, or you hold the mask on. I'll do the 2 breaths, okay? 15 litres of oxygen.
Okay, ready when you are.
Thank you. 29,
doesn't need to be shaved, does
30.
it?
Yeah, chest does not need to be
I'm
shaved.
going to apply the degree pads around you, Laura. Keep going.
Connect electrodes.
25, 26, 27.
Stand clear.
Right, off the chest, oxygen away.
Analysing now. Stand clear. Start CPR.
Okay, it's back onto compressions.
Oxygen.
We're going to be
If you
delivering a
witness
shock,
the arrest,
so we'll keep
push
oxygen away.
cancel.
With compressions, Laura. We'll be shocking in about 5 seconds. Oxygen's a metre away. No one else is here.
Shock advised. Stand clear.
Okay, Laura, step
Push
away from
shock
patient.
button.
Everyone stay here. We're shocking now. Okay, energy delivered. Back on the chest. Back on with oxygen.
Start CPR.
Let me know if you need to
Provide
take over.
rescue breath and chest compressions.
20, 21, 22, 24, 25, 26, 27, 28, 29, 30.
1, 2.
Seven, 28, 29, 30.
Emergency equipment is vital in the management of medical emergencies and cardiac arrests. All clinical areas have an emergency trolley. It is your responsibility to familiarise yourself with the location of your nearest trolley if required in an emergency. The trolleys are tagged to preserve the contents, and the trolley's external contents need to be checked on a daily basis. The trolley's internal contents need to be checked weekly or monthly, depending on the site you are working at. These trolley checks are audited by the resuscitation department, and the results are fed back to you and your line managers. Most of the kit on the trolley can be replenished from ward stock. Certain items are stored in the top-up cupboards, and replacements can be collected from there 24 hours a day. As soon as the trolley has been used in an emergency, it is imperative to restock, ready in case of another potential emergency. Any issues getting hold of kit or equipment failures, please contact the resuscitation department or clinical engineering. Out of hours, you can contact the clinical site management team. The Trust follows the Pan Dorset Do Not Attempt Cardiopulmonary Resuscitation, Allow a Natural Death policy. This can be found on the intranet. If the patient comes into hospital with a pre-existing DNA CPR form from the community, this should be considered as valid, but does require review on admission to ensure it remains appropriate in the current situation. It should be noted on the document itself that the review has happened. If an indefinite decision is made whilst in hospital, this will follow the patient home at the point of discharge and prevent unnecessary resuscitation events in the community. If the form has a review date stated on it, please make sure it is reviewed in a timely fashion. The forms are completed on paper currently at RBH and completed electronically on EPR at Poole. Either way, both forms are on red bordered paper and situated at the front of the patient's medical notes. This is the copy that the patient will take home with them along with their inpatient discharge summary at the point of them being discharged. If the patient has capacity, they must be aware of the presence of this form before they are discharged home with it. If they don't have capacity, it must be their carers or next of kin should be aware of its existence prior to discharge home. Equally, the form should have been validated by a consultant before the patient is discharged home with it. If the patient has a DNA CPR Allow a Natural Death form, they should also have a treatment escalation plan completed. These are a fantastic way for the patient's own medical team to leave instructions for on-call teams as to the level of escalation that is appropriate for that patient. Best practice is for all patients to have a treatment escalation plan. In reality, we're a little way off this happening, but things have improved greatly during the pandemic time. A treatment escalation plan or DNA CPR Allow a Natural Death decision can be changed, reviewed or cancelled as and when the patient's condition changes. It is not set in stone. And it is important to note that these decisions are medical decisions based on the best interest of the patient and not subjecting them to treatments that would not be of benefit to them. Should this presentation raise questions or concerns for you, please do bring them to your face-to-face practical session. We will hope to be able to answer them then. Or feel free to contact the resuscitation departments on either site. Bournemouth, the extension number is 4664, and Poole, the extension number is 2010. We will be happy to help. So thank you for your attention. In summary, in this session we've considered that early detection of deterioration is key in preventing cardiac arrest and death. Good quality CPR is fundamental to a good neurological recovery post-cardiac arrest, and early defibrillation is key to reversing shockable cardiac arrests. Optimal post-resuscitation care improves the quality of long-term survival. We look forward to seeing you on your practical session.